Our immune system has billions of T cells. We could actually engage more or less all of them to be equipped with the BiTE modality. So here you see a BiTE-equipped T cell attacking a cancer cell. Through the presence of the BiTE technology, the T cell is capable of recognizing the tumor cell as an enemy and then destroying the cancer cell, attacking the next cancer cell, and so on and so forth.
The mainstay treatment for polycythemia vera is episodic therapeutic phlebotomies. In addition, most patients are also treated with low-dose aspirin, and those patients that belong in the high-risk category are often also treated with cytoreductive therapy. PTG-300 is a novel therapeutic approach to treatment of polycythemia vera. PTG-300 is a hepcidin mimetic. Hepcidin is a negative regulator of iron metabolism. Unlike phlebotomy, where a volume of blood is physically removed from a patient to achieve the goal hematocrit of less than 45% in most patients, the way PTG-300 works is that it eliminates the flow of iron into the plasma, and it becomes not available for erythropoiesis in the bone marrow. Therefore, production of red cells is decreased and hematocrit is controlled that way. Eligibility criteria for this trial were fairly straightforward. Patient had to have a diagnosis of polycythemia vera, and they needed to get at least 3 phlebotomies in 6 months prior to enrollment. So we're showing data for 18 patients that were enrolled at the time of data analysis. 60% of these patients were male. Majority of patients required 3 to 5 phlebotomies prior to enrollment in the study, so 6 months prior to enrollment. About half of the patients were treated with phlebotomies alone, and the other half of patients were treated with phlebotomies plus either hydroxyurea or interferon. And about 23% of these patients had a prior history of a thrombotic event. About 60% of patients had JAK2 allele burden that was more than 50%. PTG-300 was administered as a subcutaneous injection on a weekly basis. Patients were self-administering the medication. Everybody started on a low dose, and on a monthly basis, the dose was titrated up with the goal of keeping the hematocrit below 45%. So what we found during the dose finding part of the study is that patients no longer required phlebotomy. The need for phlebotomy was eliminated in this heavily phlebotomy-dependent patients, which was very exciting. We also looked at the iron parameters in these patients, and at baseline, all patients were iron deficient as indicated by their ferritin levels. It was very low in the iron deficiency range. When they started on treatment, after as soon as actually 4 weeks of treatment, their ferritin level was no longer in the iron deficiency range. As I mentioned already, this is a novel approach to treatment of polycythemia vera, and it really does appear to be very effective in eliminating the need for phlebotomy. As more patients are enrolled on the study and the duration on study continues, we will have more robust data on safety and efficacy of this drug. We are also very interested in examining the effect of PTG-300 on symptoms of PV, and some preliminary data suggests already that there may be some improvement in PV symptoms in these patients, which is very exciting. Overall, long-term, it would be really good to know if this treatment has any effect on the thrombotic risk of these patients.